Hello, everybody, and welcome to Unit 3, Dementia. There we go. Okay, so kind of counter to what I said last time, when I said we're going to discuss psychological diseases, but they're really not going to make a large impact in your day-to-day experience with geriatric patients. Dementia is going to make a huge day-to-day impact. You will see many, many patients that have some form of dementia. So, kind of just go over this again. Dementia is a disorder of mental processes due to physical brain damage. It's marked by memory disorders, personality changes, and impaired reasoning. Dementia can literally be thought of as chronic brain disease, as opposed to psychological diseases where the problem was essentially chemical communication in within brain cells, or lack of some sort of neurochemical that was necessary. In this case, the brain is physically damaged. It's degraded in some section or the other, and it's physically no longer able to do what it used to be able to do. You can think of that in the same way. Asking people with dementia to do things is similar to asking someone with COPD to run a marathon. It's physically not possible anymore. And that's important to keep in mind as we look at this. So, how common is it? Well, I'm not going to read the whole table of numbers. You can check it out right there if you'd like to. But the important thing to note is that it does increase with age, and it jumps significantly with each portion. We go to a quarter of people from 80 to 89 that have some form of dementia, and almost 40% have some form of dementia by 90. So age is probably the biggest deciding factor. So, what is it? Again, it's a physical breakdown of some part or parts of the brain. All forms of dementia are progressive, incurable, and fatal. There are multiple types of it. The types we're going to discuss are Alzheimer's disease, frontal temporal disease, dementia, and Lewy body dementia, and vascular dementia. So, diagnoses. How do we know if someone has this? Dementias may be thought of as syndromes in that they're identified through clusters of signs and symptoms initially. The type of dementia is related to the area and type of damage in the brain. So, the way that the signs and symptoms present are what identifies the dementia in question. Now, lately, and by lately I mean within the last few years, I have seen a trend away from identifying specific dementia types and just diagnosing dementia without any further clarification. And honestly, in a way that makes sense, and we'll go over why that is shortly. The most common form is Alzheimer's. 60 to 80% of people that suffer from dementia have Alzheimer's. In 2020, that was about 6 million cases. 50% of Alzheimer's patients present with AD pathology solely, which means that, again, 50% present with some other form as well. Similar to other ones, similar to, as I said earlier, cardiac disease, psychological disorders, you're at a greater risk of developing further types of dementia if you have a type of dementia. It is more common in the elderly, and Alzheimer's is associated with a buildup of beta amyloid plaques and tau tangles. Alzheimer's progresses slowly. It's approximately 3.5 to 5.5 years from the onset of symptoms to an actual diagnosis of Alzheimer's. Previously, it was diagnosed completely from the symptom clusters and how it presented. Now, the severity and the classification of Alzheimer's is still done this way. You may have seen the Mini-Mental or the BIMS. Those are two tools used to identify what type of dementia and to what degree of severity we're talking about. An actual diagnosis can now be performed with dyed cells or dyed slides that reveal tau tangles in the cells. I have an onion here. If anyone has ever done Alzheimer's orientation or study before, you'll know the onion is ubiquitous with Alzheimer's. Alzheimer's is a staged progression. There's not a lot of agreement on how many stages there are or what constitutes shifting from one stage to another, but everyone agrees there are stages. There are 4 to 7, according to different sources. Alzheimer's does present with slow progressive faculty loss. Memory loss is the first thing that's noted and impaired, but as the disease progresses, you run into impaired communication, disorientation and confusion, and then eventually difficulty with ADLs, and then with just swallowing, speaking, walking. One of the things people mention is what's learned first is lost last. So Alzheimer's is kind of a regressive loss of memory. And that's the first area that is attacked by the disease. So you'll see people sort of travel back in time. They will begin to forget things like their children are grown, they have grandchildren. They may not recognize family members because they don't look the way they're expecting them to. Also, one of the things, just as a side note, as a tip, I never assume that somebody with Alzheimer's remembers who I am. Every time I go into, even in like a long-term care setting, when I have seen this person at least 4 times a year for the last 5 years, I will still walk in and introduce myself and explain who I am and what I'm here for, because it's not fair to them to assume that they remember who you are. As the disease progresses, they may also develop delusions. So, the pathophys of Alzheimer's. 2 things are ubiquitous with Alzheimer's. One is beta amyloid plaque buildup. These are protein fragments that build up outside of neurons, and tau tangles, which are long, twisted protein chains inside the neurons. Like I said, while these 2 go hand in hand, you see beta amyloid and tau tangles every time you see Alzheimer's. It's unclear if these are causes or byproducts or symptoms. We don't know how they relate. We simply know that they do. Alzheimer's is also marked by a decreased volume of the brain. You can see up there, healthy brain versus someone with advanced Alzheimer's disease. It literally, the brain is degrading. Also, very quickly here, I'll mention tauopathies. Tauopathies are a proposed cluster of diseases or family of diseases, which Alzheimer's would be the most prevalent of. Alzheimer's patients are known to have decreased autophagic response. If you remember, autophagy is when parts of a cell or the cell itself are removed and destroyed to make room for healthy cells, healthy parts of cells. And Alzheimer's patients have a marked decrease in autophagic response. Tau tangles aggregate into neurofibrillary tangles, and aggregate simply is a fancy way of saying they clump together to form neurofibrillary tangles. The tangles are formed from a hyperphosphorylation of tau microtubules. Get ready for this a lot. I know I've already said that a lot within this course, but prepare for today. The mechanism and the trigger is not well understood. We know, again, that there's a cluster of diseases that present with tau tangles. We don't know if it's if the buildup of tau tangles is the cause, or if it's an effect of the disease process. Here's some fun reading for you if you'd like to catch up on your tauopathies in Alzheimer's. The next one we're going to look at is frontal temporal dementia. Now, frontal temporal dementia is actually fairly rare. There's only 50 to 60,000 cases in the U.S. annually. It has an outsized representation within facilities simply because of the area of the brain it attacks. It attacks the frontal lobe and the temporal lobe, as the name would hint, because again, scientists are terrible at naming things. Now, the frontal and temporal areas are responsible for judgment, analysis, and behavior, which means that patients with this will kind of lack their edit button that we all have. They have an inability to make very good rational decisions, and their behavior may be very completely different from what they used to be. It also strikes fairly early. Compared to, if you remember Alzheimer's, the older you got, the higher at risk you were. FTD, 60% of the cases in FTD are found in people 45 to 60 years old, so it hits early on. There are two major different types of frontotemporal dementia based completely on what part of the brain is being attacked. There's the behavioral variant, which with that terrible BVFTD shorthand acronym, that's the word I'm looking for. This one's characterized by prominent changes in personality, relationships, and conduct. So this is kind of this is the behavioral one. This is when people act differently. They've lost their ability to make judgments, make reasonable decisions. They've lost that edit switch, so they may say things that are very inappropriate. The other version is primary progressive aphasia. This affects language skills, speaking, writing, and comprehension. But wait, there is yet more breakdown. There are two variations of PPA. There's the semantic variant of PPA, in which individuals lose the ability to understand or formulate words in spoken sentences. There's also non-fluent agrammatic variant of PPA, in which speaking is possible, but it's very hesitant, labored, or ungrammatical. So talking to somebody like that, you may have to repeat your question in several different ways for them to understand it, and their answer to you may take some analysis on your part to figure out what they're trying to tell you. The next type is Lewy body disease, which is a disease that group that involves Lewy bodies. See frontotemporal dementia about naming things. Lewy bodies are proteins called alpha-synucleins, I always get that wrong, that build up in the brain. It typically manifests later than 50 years, and there's about 1 to 1.4 million victims of it. Lewy body is an extremely aggressive form of dementia, whereas frontotemporal may take a while, Alzheimer's takes a long time. Lewy body is very aggressive, and again, all forms of dementia are progressive and fatal. Lewy body is very quick and aggressive about it. One hallmark of Lewy body that separates it from other ones is that visual hallucinations are common in Lewy body dementia, and they happen very early in the development of the disease. People with Lewy body have a sensitivity to anti-hallucinogenics. So they're having hallucinations, and there's nothing that we can really give them to help. They have fluctuations. Lewy body presents with less of a steady decline than other forms. There are fluctuations in cognitive ability, attention, and alertness. And instead of having memory issues, they have more trouble with complex mental tasks. So they may be able to remember their family, who they are, where they came from, and you. But if you give them something like a puzzle or a logic puzzle, something like that, they'll struggle with it. Very briefly, I'll mention Parkinson's disease dementia. Some members, it's a club. Some people that suffer from Parkinson's disease will develop dementia. The physical symptoms always manifest first in Parkinson's, but some people will then develop dementia. And again, no known trigger, no known mechanism. We're not sure why it happens. We don't know why some people will develop it or not, and we really don't have a good way of predicting who's going to develop it. And finally, vascular dementia is a deterioration of brain matter due to vascular insufficiency. If you'll cast your mind back to wounds, when we talked about vascular wounds, and this was kind of a slow almost cave-in and deterioration of the skin and the flesh in that area because of venal insufficiency or arterial insufficiency. This is the same idea. It's not like a stroke, which happens very acutely. This is deterioration over time because of a lack of sufficient blood flow to the brain. It's not really a disease in and of itself so much as it's a separate causal descriptor, if that makes sense. Vascular dementia can really form anywhere and can attack any part of the brain. It completely relates to where the blood flow is not making it. Come on, technology, work with me. There we go. All right, so now that I've terrified you with this, what are the risks? We know for a fact that there's a family genetic component to dementia, and it's the same as other types of diseases that have familial links. The closer in relation somebody is to you, the higher your risk becomes. Your great Uncle Todd developed it, and then nobody else has. Maybe there's an increased risk, but not much of one. If you have a parent that has it or a sibling, your risk is much greater. Black and Hispanic ancestry seems to be a risk factor. Again, we don't know why that's the case. It just seems to be the case. Age and this is both parts, right? This is age, as I said earlier, when you just live more times to spin the roulette wheel and see what happens to you. But also, age is a not a determining factor, but age is a distinct risk factor in and of itself, at least for Alzheimer's. Diabetes. Having diabetes puts you at a higher risk, and there's a distinct connection between diabetes and dementia. We don't know how it works yet. We can't explain it. But we know that it exists, to the point that some people want to refer to dementia as type 3 diabetes. Also, cardiovascular risks. Obviously, you can see it from the vascular dementia. Any kind of cardiovascular disease, it puts you at risk for developing vascular dementia. So what can you do about it? The good news is there is stuff you can do. Aside from the standard eat well, try to sleep well, be physically active. Education seems to be, if you will, a dose-mediated protectant, like a prophylactic to dementia. Looking at the statistics, about 5.5% of college graduates will develop dementia. Some college brings your risk up to 6%. If you have graduated high school, it's 11% risk. And if you have less than a high school equivalent education, your risk is about 20%. There's also some evidence in the literature that suggests that remaining cognitively active reduces your risk. The proposed mechanism on this is that, we used to think that the brain just stopped. Once you were an adult, your brain just stopped functioning. We now know that's not true, that there is neuroplasticity and the brain is constantly remolding itself. And the theory is that learning new things causes your brain to rewire, if you will. And that having the more routes, more pathways, makes it easier for your brain to route around a damaged area, if that makes sense to you. That sounded bad. If that makes sense, you understand that the more pathways there are, the more ways there are around a damaged area of the brain, which may lower risk. The medications, again, there is no known cure for dementia. We have medications. They may slow progression. They don't work for everybody. And I'm just saying now, the mechanism's not clear. We don't know why these work. So the ones you are likely to see are Aricept, Exelon, Namenda, and Remenil. That's generically donepezil, rivastigmine, memantine, and galantamine. And you'll notice that 3 of those are in the same family. They're essentially the same drug. They work on different stages of dementia. But given that there's a disagreement in how to stage people with dementia and where someone would be, typically you'll see more than one of these at a time given. You'll at least two. The two most common ones I see are Ariset and Namenda, and that's because we're not 100% sure where somebody is, hoping to land in the right spot and hit them with something that's helpful. Now, here's where you guys come in. And dementia is an area in which you can make a tremendous amount of difference. Dementia patients are at extremely high risk of malnutrition. If you'll remember when we broke down the risks earlier, the person with the highest amount of risk was an elderly woman with dementia. She had the highest risk of everybody to develop malnutrition. Because dementia is so varied and so different, interventions have to be tailored to the individual. Some examples are adaptive wear, which is just things that are not the standard dinnerware that you might use for in place of what you would normally get. We have divided plates or plate guards, which are either, if you think of like the kind of like standard picnic plate that has the styrofoam one that has the 3 compartments in it. That's what a divided plate is. It's just the compartments are much deeper and it's made out of a heavier material. Plate guard is a wall that's made of metal or plastic that you clip to the side of a plate to give them, again, something to like mash the food up against so they can scoop it up. Weighted or built-up wear is something to consider. Remember that a lot of dementia patients, as they progress, lose fine motor function. And weighted wear is specifically for people that develop tremors. If you have a tremor, if you have a weight in there, it makes it harder to have that tremor. It's just a counterbalance to the weight, or to the tremor, I'm sorry. Built-up wear is for, now, if you guys remember, back in Unit 1 with Henry, and it mentioned that he's using a pen while he has an IV in his hand, and he's frustrated about this, but still able to do it. And I mentioned in a couple of people's feedback, at least, that his ability to that he can use his offhand is impressive sign of having good muscle mass and dexterity, but also that he could use a fine tool like a pen. Hold on a minute here. Do I have a pen? I don't have anything right here nearby. But if you think of like a fork, let me make sure I'm shot here. You like scoop it down, turn it to your mouth, eat. Or if you want to go continental, you can flip it over, stab the thing into your mouth. That's a lot of fine motor movement. That takes a lot of dexterity and agility and control. Somebody with advanced dementia may not have that ability. And so instead, the built-up wear allows them, one, to grab something that's not so small. So it's a much thicker one. It's much easier to grab onto. And they can then use, let me turn here a little bit for you. They can use their elbow, their shoulder, and their back to move the food to their mouth instead of using fine finger and wrist control. It's not elegant, but it does work. Another good one is brightly colored or contrasting flatware and plates. Just for example, for this area where I am, a classic meal would be a country fried steak with white gravy, mashed potatoes, and then maybe, say, corn. That's brown and white and light yellow on a white plate, probably. Now, for you and I, that's fine. We don't have an issue with that. But if you have a visual acuity issue, or if you have a problem with, if you have difficulties assessing the environment, that may just look like a big pile of white to you. So studies have found that changing the colors of the plates actually increases intake quite a bit. So there is some softer data that red is the best color for this, but that's not set in stone. But just as an example, the 2 facilities that I work with that have dementia patients use Fiesta ware, brightly colored plates. That also gives you the option that if you find somebody, if Miss Abercrombie does really great with the teal plates, you can make sure she gets a teal plate. So that's why they use them. But anything like that, I'm not here to plug Fiesta Ware. I'm saying that's the one that we use. More interventions, limited distractions. Now, a lot of us in our generations here like to have something going on while we're eating. Whether it's music or it's a TV show. Even when my wife and I are like we're eating together, we got something going on in the background. The generation before us came from an era when that was not so. Also, there is a theory that your ability to focus is kind of a limited resource, and that's why if you're ever driving along, you're looking for an exit somewhere, and you're trying to really focus on not missing this exit and weaving through traffic. Say you're in downtown Houston or something like that, if anyone's been there. And you'll turn down the radio. And the reason for that, some psychologists have suggested, is that we have a limited amount of focus available to us. And your brain doesn't want it diverted off to the radio when it really needs to find the stupid exit it's looking for. Other ones are finger foods. Partially that goes back to people who have limited dexterity. It's easier to just pick something up. Now, it's important to note that finger foods, in this case, are not things like sandwiches, potato chips, carrot sticks, things that we would normally think of as finger food, fried chicken, something you would normally pick up and eat with your hands. We're talking about, in this case, that would be one, very boring eventually, and two, kind of nutritionally limiting. We're talking, in this case, finger foods are anything you can pick up and eat. So a grilled chicken breast, as long as it's not searing hot, is a finger food. Plain buttered rotini or bow tie pasta is a finger food. Green beans or broccoli are finger foods. The other benefit to this is you can give them food that can be eaten on the go. So not only is it good for people who are manually challenged, but this is kind of un-PC to say I would never say this to a patient, but sometimes with some forms of dementia, you have limited amounts of focus that somebody has. And it's a little bit like getting a 4-year-old to eat. You have a small window. If those of you who have done this, there's a very small window before they're like, bored now, and gone. And that's kind of the same way for some people with dementia. So, there's a point where you're like, oh, well, Mr. Smith is leaving. We're done today. We're not going to get him back until tonight. So if you can have some food that you can give to somebody, and whether that's food that you make in-house or if there are special items like high protein, high calorie cookies that you can give somebody, and something they can carry around with them, whether it's like they're bored and they're ready to leave, but you can stick it in their hand as they go, or if they're people that are fidgeters or like to pace, but you can put this in their hands so they can eat while they go, that's great. Smaller, more frequent meals also helps with this, especially people who have a limited concentration span. Maybe you can't get them to eat a full meal, but if you can get them to eat, say, half a sandwich and a fruit cup and some water or milk or something, and then a couple hours later we try again, that's fine. Your body's not picky. It doesn't care how it gets its calories. 3 meals a day, 6 meals a day, it doesn't matter. It'll take it. The sweetness. Because dementia, especially Alzheimer's, is regressive often, we go back to, patients will go back to previous behaviors. Now, think back. How much do your kids, when they're, or you, if you can remember when you were younger, how big were you into sweet? A lot, right? For some reason, interestingly, a lot of times the interest in flavors changes to salty as you go to adulthood. It then will flip back to sweet, and there have been some suggestions that sweet is the last taste sensation you lose. So think about sweetening things. I know it sounds vile, but there have been dementia patients we've worked with that we have put honey or maple syrup on the whole plate, and they ate it. ends because they can actually taste something. That's a possibility to consider. Also, oral supplements, and this also relates kind of to sweet. You may find, like I do, that Ensure kind of tastes like liquid vitamins with sugar. I'm not a big fan, personally, as far as like, do I like it? No, I prefer to skip it. But if you have a limited taste palette and sweet is what you can taste, and you can give someone an Ensure and they can carry it around with them, and I'm not plugging Ensure, Boost, Glucerna, whatever you want to give them, doesn't matter. And they can walk around with that bottle or that carton, that's great. That's just, more calories, another way to try to get food in them. Now, the last thing is, when everything else fails, the inclination of a dietitian is going to be enteral. And that's not a great choice for dementia patients. The American Geriatric Society and the Dietetic Association and Aspen all agree that there is not a lot of evidence that supports the use for enteral nutrition. At that point, we're getting into quality of life, end of life choices. It also just doesn't appear to do a lot of good. It may make their numbers more numbery. It may increase their electrolyte balance and their glucose, but it doesn't seem to improve their quality of life in any way. And really, that's the important part. What is their quality of life? And and then we need to consider also the wishes of the patient, the family, and then we're rolling into the next part of this, which is end of life decisions to make. Guys, that's dementia. Again, any questions or concerns, give me a holler. I'm glad to talk to you about it. And I will catch you for end of life when we meet again. Have a good one. Bye.